My name's Laura McEwen-Smith. I'm a managing consultant with the CLEAR programme, and I'll be hosting today alongside my colleague Laura Breach, who's strategic lead across the women's health portfolio more broadly, here with the CLEAR programme. And I'm delighted that we're also due to be joined today by Dame Leslie Regan. Dame Leslie's played a leading role in shaping the National Women's Health Strategy, and she continues to champion improvements in women's health services across England as Women's Health Ambassador. So I'm really looking forward to hearing her insights shortly on the future of women's integrated neighbourhood services and how neighbourhood-based models of care can improve access and experiences for women. We've got about an hour together today. If we just hop to the next slide, please, Maria. We'll cover some background on CLEAR, hear from Dame Leslie, take a short look back at what phase 1 taught us, and then we'll walk through the detail of this new opportunity and our timeline before opening up, as I say, for as much live Q&A as we can fit in. Anything we don't get to live or that needs a fuller written answer, we'll follow up with an FAQ note after the session today. Next slide, please. So I want to spend a few moments just talking about what CLEAR is. Some of you will be well familiar and others not so much. So next slide, please. A brief introduction to, for those who are new to what we do. CLEAR stands for the Clinically Led Workforce and Activity Redesign Programme. It was originally developed in partnership with Health Education England and is now sponsored by NHS England, Regions and Systems, and hosted and delivered in partnership with East Lancashire Hospitals NHS Trust. Next slide, please. We've got a core idea at the heart of what we do, and that's to put clinicians at the heart of decision making and combine their insight with data analysis to design new models of care and workforce. Next slide, please. Since we started, CLEAR has completed more than 200 projects across England, spanning key NHS priorities, so urgent emergency care, mental health, primary care, we've got elective recovery, ophthalmology and others on there. Women's health is the focus of the work we're presenting today. We supported the NHS through the pandemic, and we continue to support the restoration and transformation of services. Next slide, please. I'm hoping Leslie is on the call. Just checking my list.
Yeah.
Leslie, here. Welcome. So I'm delighted to hand over to Dame Leslie Regan. Leslie's been a fantastic supporter of the CLEAR women's health work, and there's nobody better placed to set out why this challenge matters and why we believe a bundle of pathways delivered within neighbourhoods is the right answer. So Leslie, I'm going to hand over to you. We'll stop sharing the screen at this point. I just think it would be nicer to engage with you speaking. Thank you.
Laura and I, thank you very much for inviting me. Laura and I agreed earlier that I wouldn't do death by PowerPoint for you. I would actually just talk. So I'm a gynecologist and I have been for over 4 decades. And I had become progressively more frustrated as a clinician, I work in central London, by the sort of lack of care that women were getting, what I would call their maintenance care. So the first thing I'd like to emphasise is that what we need to do if we're going to improve or close the gender health gap for girls and women is we've got to move away from the disease intervention model to the prevention model, and also recognise that although women visit healthcare professionals much more frequently than men, most of the time they're visiting them, they're not sick. They're actually trying to do something to maintain their health. They're trying to get their periods sorted out. This is not an illness, but it's something that happens 12 times a year for 40 years of your life. Or they're pregnant, and that's not an illness either for most women. And the other thing I'd like to emphasise, of course, is that the demographic of our population is changing very dramatically. So when I came out of medical school, women disappeared at the age of 50 because they were no longer reproductive. They'd stopped having pregnancies by then. And I think it was fair to say that many of our policymakers and certainly our politicians viewed women as maternities. Now, I'd be very surprised if there are more than 1 or 2 people on this call who are women who've been pregnant or will be pregnant, if they haven't already tried that, for more than 2 or possibly 3 years of their lives. And I mention that point because I have the great honour to be the mother to 33-year-old twin daughters. And my twin daughters are the first generation of woman who is going to live longer post-reproductive than she was reproductive. And so what I'm trying to do with the women's health strategy and also the refresh was to try and get people to understand that we have to view women's health across the life course. And what happens to you in every decade can affect the next decade and so on. And particularly because so many of the things as a gynecologist or reproductive person I was getting frustrated about were things that were very, very basic, simple period problems, not being able to access contraception. You may be a little bit surprised, unless you also have been worried about the state of women's health, that 45% of all the maternities in this country currently are unplanned. And I'm not saying that they're unwanted, all of them, but many of the reasons why the abortion rate now is higher than it's ever been before is because middle-aged women are not able to source the long-acting reversible contraceptions that they wish to. So, for example, they may have completed their families and they're waiting on a waiting list to have an implant or a Mirena coil put in, which is often dually helpful for sorting out their heavy periods or their pelvic pain, as well as being a first-class contraceptive. So you can see that there's lots of things that are going on where women are at a disadvantage because their maintenance healthcare and their access to very basic facilities and interventions is made very difficult. And that's just about the reproductive stuff. I mean, then we could go on to the maternities, and we are still in the wake of the Ockenden and Amos inquiries. We're still all shaking from the number of awful things that have happened, and yet still we view maternity as a sort of a siloed area, and we forget that when women go through pregnancy, their physiological response to the pregnancy is often really telling in terms of what problems they may face later on in life. So if you've got a bit of high blood pressure or preeclampsia, I know, I'm looking at Sarah Hughes in Torbay, she's straight in front of me. I know, Sarah, that you're going to get cardiovascular disease 10 years earlier than your next door neighbour who didn't have high blood pressure or preeclampsia. And of course, if you became a gestational diabetic or you get gestational diabetes in your pregnancy, then you are going to be a type 2 diabetic before the age of 50. And that's also the case with mental health problems. So mental health problems are particularly prevalent in the postnatal period, particularly depression. And we know that that means that women are going to need to consult mental health services at a later date and will need support. And yet we just ignore all these things. So I kept, for years and years as a frontline obstetrician, I kept copious notes about all these things happening to women. And the moment the baby's delivered, then we forget all about it. So one of the first things in the Women's Health Strategy that we published 4 years ago now, I was appointed in June as the ambassador, I think to try and persuade the front line that we had to do some things in a rather different way. And then the actual report came out in the August of 2022. And for that first couple of years, we did, if you remember, we had for the first 2 years up until July 2024, when we had a change of government, we had no less than 5 or 6 secretaries of state for health. So I'm really quite impressed that we got anything done, actually, but we did. And one of the things, like, I'm not going to go through the whole list of the things that we got over the line, but there were quite considerable ones, and I'm happy to talk about those in the question time, if that would be helpful, or discussion time. But the one that I want to focus on, because it is so relevant to the neighbourhood framework, are the women's health hubs. Now, they've gone through certain naming things. So first of all, I said, well, what do you mean women's health hubs? And they assumed that this was a place-based thing, a place-based hub. And I said, no, we could also have virtual hubs. So we've designed all sorts of different models, because what will be useful for Laura where she lives may not be the same as what the people in Hampshire, that Natalie, who's on the call in the audience, needs. And so city and rural are going to be very different, and seaside deprived are going to be different, and the age demographic of your population will demand different things. But what we said is that in the health hub, the idea is that we're going to wrap services around the girls and women, not make the girls and women run around all the different services. So if one of you was to come and see me because you had painful heavy periods and I was going to fit a Mirena coil for you, which is such a fantastic way and a non-invasive treatment, then although I had a speculum in and you're probably feeling uncomfortable, and I hope that you've been impressed that I've given you lots of local anaesthetic so that you don't have a horrible memory of this episode, I'm not meant to do your smear because smears are commissioned by another part of the system. So you can see that the commissioning has been a big problem and has been the cause of, I think, many barriers here. And that's what we were trying to sidestep, if you like, or work around by having the hubs where we wrapped it round to everyone. So we got quite excited about the hubs, and as I say, there were virtual models where someone very senior would sit and triage the referral, so that would mean that if, for example, I had an episode of postmenopausal bleeding, there's no point in sending me to gynae outpatients to have an ultrasound scan or some blood tests, because we know that the gold standard is I need a hysteroscopy and I need a biopsy of the womb lining to exclude anything sinister. So it was, rather than make everybody go through that gateway in secondary care, that we wanted to rationalise the care that women were getting. And certainly in the hub models that have used that triage system and then signposted women to where they need to go to, they have reduced their waiting list for secondary care. The famous one is Tower Hamlets. They have 2 hospitals with secondary care facilities, Whitechapel, the London Whitechapel, and Mile End. And they reduced their referrals year on year over the last 3 years by using this model of triage from 86% down to 26%, which is a massive fall. And this is basically looking after women in the community. So we would say by the time we got to July 2024, what we were trying to do with the health hubs is make sure that no girl or woman went to secondary care in the first instance if she had period problems, if she had problems with her cervical smear or she needed a colposcopy, or if she had menopause problems or needed contraception, and even if she had urinary troubles, she would need to be able to access bladdermetrics and physiotherapy out in the community. And only if that wasn't successful would she then need to be referred into secondary care. So it's been a very successful model, and we've now had a change of government. And as you know, in July 2024, a new team arrived, and then they wanted to have a 10-year plan. So the original strategy was a 10-year strategy, but then they had another 10-year plan for the NHS. And you will all know that mantra about how we've got to go from hospital to community, from analog to digital, and from disease intervention to prevention. And I think really that NHS 10-year plan is a description of what happens when you do the women's health hubs well. So they decided we weren't going to call it hubs because that was the thing from a previous government, that they were going to call them community services, or they would match up with the clinical diagnostic centres that were being set up very successfully around the country. And now the new one is that we're going to call them neighbourhood hubs or neighbourhood facilities. And the WINs, the women in the framework system, would be the way forward. And so that's really what we've been trying to push in terms of the this restructuring of these facilities and women's access care. And I'm not decrying any of the other things, but if we then go on to remind ourselves that, as I said earlier, my daughters are going to live longer post-reproductive than they were reproductive, we've then got an opportunity to look at the things that are going to be really fatal for you and me. Now, often when I ask women what they think that they're going to die of, they tell me breast cancer or colon cancer or something else, usually a cancer, and it's usually something somebody in their family or their close friendship group has had recently. And they're absolutely wrong. So we now know that women are twice as likely to die from heart disease as they are to die from a cancer from any organ in their body that ever gets cancer, all put together. So we've really got to focus on the heart disease, and we know that that is a multivariate risk, isn't it? That you all sorts of things. So we've got to tackle the obesity bit, and we've got to tackle the blood pressure, and we've got to tackle the genetic or familial predispositions, etc., etc. But there's lots of things that we can do during the reproductive years to reduce the impact of heart disease later on in life. I could then tell you about all the problems there have been in basing all of the heart disease interventions and medications and treatment options are based on studies all carried out in men. And even those studies that have included some women, they've never been of reproductive age because of fear of what that might happen to the baby. So I think that's been a major mistake in the way we've designed things. And then we can take the other big killer of women. There are three: the heart disease, the osteoporosis and frailty, and the dementia. And all three of them, we may not be able to cure them completely, but what we're aiming to do with the revised strategy is to push them or postpone them right to the very end of life. Because what I think is important for me to ensure that everybody has a feel for is that there have been 4 myths about women's health that we really need to debunk once and for all. And the first is that women are little men. They're not. They're very different from men. They're not just smaller, but they are very complex. They have all these complicated hormones, which is one of the reasons why pharma and femtech find it very difficult to do studies in women, because of the cyclical changes in their hormones. But they have also very different disorders, and they have also a disproportionate prevalence of illnesses compared to men in some fields. So, for example, autoimmune disease like thyroid or rheumatoid arthritis, they are very, very common in women. Migraine is much more common in women. When we talk about osteoporosis and frailty, the prevalence of osteoporosis in women is about 22%. It's only about 5% in men. So it's a really, really important thing. And preserving your bone density with a combination of aspirin, possibly estrogen replacement, and healthy exercise is really, really important, and something that we have not paid enough attention to, although everybody knows that it's a very good thing to do to not become frail. So the second one is that, as women's health is all focused in the reproductive years, it's just sexual and reproductive health. And I think I've already persuaded you, hopefully, or I'm sure you knew that that's not the case. There's a lot of other things too. And that as women are living much longer now, they're going to need to think about these things. And we've got to design our health services to cope with that as well. And one of the other interesting things when I talk to pharma, or I talk to places like the NIHR and say, well, why don't you invest more money in women's health research? They usually say to me, well, it's a niche market. And I just have to ask you all, what part of 51% of the population can possibly be classified as niche? So I really don't buy that. But possibly the most important thing for the relevance of CLEAR and the pathways is to understand that it was always assumed that the real burden of ill health and lack of productivity and absenteeism from work or from one's unpaid caring roles was at the end of life, because that, of course, is what happens with men. So what's really important is that if we really drill down into the gender health gap, and I'd be very happy to share with you the presentations from McKinsey, who've done this beautifully with the most wonderfully explicit slides. What they show is that actually the big lack of productivity and the big part of the gender health gap is between the ages of 20 and 55, not in the latter years. So we've really got to focus on all these things in the maintenance care that we're doing so badly, or have been doing so badly historically, and we've got to get those right, so that then I can tell my daughters that we are going to postpone them having cardiovascular disease and frailty and osteoporosis and dementia right until the end of their lives, because we're going to then reapportion those resources in our health service into looking after those problems, because the reproductive stuff will have been sorted out. I'm simplifying, but I'm obviously saying it to be a little bit provocative. So this isn't complicated, but what has been very difficult, I think, is trying to persuade clinicians, instead of thinking in silos about their particular organ or patch, that we've got to think about women's health across the life course. And what interested me when we were trying to embed the women's health hubs, now called neighbourhood hubs, into the integrated care boards a couple of years ago. Every time I went to a different integrated care board, and there were 42, and I visited them all, someone would say to me, who is in the cardiovascular team or the mental health team or the renal dialysis team, oh, we'd really love to do that. There's lots of things we'd like to do in the community that we don't think women need to come into hospital for. So I think there's been a lot of change in the way we've thought about it. But of course, the task that Laura and her team from CLEAR have got now is how we're going to implement this at the local level, and make sure that all clinicians understand what they need to do to contribute towards it, and also that the commissioners understand what they need to commission for in their particular patches, which is going to be very different depending in which part of the country you live. Should I stop there, Laura, and I'll invite people to ask questions, because I've deliberately not given you the 117 action points from the revised Women's Health Strategy, which Mr. Streeting announced was going to happen about a year ago. Everybody was completely shocked, and he was being asked a question at a big conference, and he turned to me in the front row of the audience and he said, "Oh, don't worry," he said, "I've asked Leslie Regan to revamp the strategy." And immediately I had 155 special advisors on the phone. When was that? Why didn't you tell us? I said, "Well, I haven't heard about it before, but not to worry. One of my mantras in life has always been, never waste a good crisis. You can always get really good things that come out of a crisis. And also, I've also learned that opportunities very, very rarely make appointments. And if you don't grab the opportunity, it passes you by and then you always regret it. So I'm going to ask you of the things that you'd like me to expand on further, without going into the 117 points in the revised Women's Health Strategy. Which you can group basically into things about women. We've got to listen to women. We mustn't ever again have 80% or 84% it was of 100,000 respondents to the original public consultation, women telling us that they had been ignored, gaslit, disbelieved when they went to have problems. And we just cannot have a situation in which 1 in 3 referrals to outpatients are for heavy periods and painful periods that then sit on the waiting list for nearly 2 years. And for anyone who's still a little bit sceptical about all this, if I explain to you that one of the things that Gillian Merran, who's the Under Secretary of State and Baroness Merran in the Lords, asked me to do back in November 2024, a few months after the Labour Party came into office and had announced the NHS 10-year plan was going to be on the way, she asked me to look at the gynecology waiting list, which I did along with my colleague Sue Mann from NHS England, who's been very involved in all this work as well, and in fact has commissioned you, hasn't she, at CLEAR?
That's right, she has, yeah.
She has, and we've worked together for many years in the past as well, and we can be quite effective. I gather sometimes that we're referred to as the terrible two, because we won't take no for an answer. And we frequently say, when people say, well, we don't do it that way, we're frequently heard to be saying, yes, but we've done it the other way, your way, so many times and it hasn't worked. So let's try it this way this time. Anyway, I digress. But what we did is we looked at the waiting list in November 2024. You can easily access the report, and it showed that there were 600,000 women on the waiting list for gynecology outpatients in secondary care. And if I tell you that 85% of those women were not going to need any form of invasive procedure or an admission to day surgery or an inpatient admission, I hope your response to me then is, well, what the hell are they doing sitting on the waiting list to go to secondary care? And then if I accept the fact that 85% of them were not going to need anything, of the women that got to secondary care, and remember that they sometimes spent 2 years waiting to get there, while their painful heavy periods disabled them, made them unable to look after their children or do their unpaid caring roles, unable to go to work a lot of the time, etc., etc. Whilst they were waiting on that waiting list, their symptoms were getting worse. And that's what you will hear frequently from women with menstrual disorders who then develop endometriosis. So you don't wake up with endometriosis one morning. You don't wake up with polycystic ovaries one morning. They develop over a period of time when your other symptoms have been neglected or not properly diagnosed into a condition. So I think that's really important to understand, and that we've shown now that of the 85%, when they eventually get there to the outpatient clinic, they are then discharged at that first visit. So if they're not having anything done to them and they're discharged after the first visit, I think all of those things could have been tackled in the community. So I'm not saying we're never going to do anything in secondary care, but we've got to reserve secondary care and reapportion the resources. And of course, that is the difficult bit, isn't it? Because Another experience I've had in life is that turkeys very rarely vote for Christmas. So there aren't going to be many secondary care chief execs and finance officers who say, oh, yes, of course you can have the money in the community. So this is going to be very much a question of persuading the commissioners and the infrastructure that this is the way to work. And I've now got a little mantra as well. When women, or rather not when women, when clinicians or when managers tell me we can't afford to work this way unless you pump Primate, my response now is always, we can't afford not to do it this way because we are wasting so much money. So if I was to show you the McKinsey data, just my last point, and then I will stop, Laura, and that is that if you close the health gap for women, we would save 36 billion sterling every year. And that is 20% of the NHS budget. And just think then what we could do, the inroads we could make into research and treatments for the three big killers, the cardiovascular disease, the osteoporosis and frailty, and the dementia. I mean, we would really transform our nation. Happy to answer some questions.
That's a really striking point to end on. Thank you so very much, Leslie. You've really set the scene for us. And I think you've given some such powerful reminders of why this programme matters, the direction of travel, and what we've aligned to in terms of the aims. I think you're sticking around till the end, and that would be great. We'll move on now. Before we look ahead to phase 2, the phase of work the expression of interest relates to, it will be helpful, I think, to take a moment and look back, because phase 2 builds directly on what we learned in phase 1. And for that, I'm going to hand you over to my colleague, Laura Breach, who led that work and is going to spend a few minutes just talking you through that. So Laura, over to you. And can we have the slide, please, Maria? Amazing. Thank you very much.
Thank you, Laura. And and thank you, Leslie. It's always difficult to follow Leslie on a webinar, so apologies for that. As Laura said, I am also Laura. I'm a managing consultant with the National CLEAR programme, and I led on the first phase of women's health work, and now manage the women's health portfolio that we have within CLEAR. And I think probably the key thing to take away from the first phase of the programme we ran is how much the landscape has changed in the last year in terms of the ambition around developing women's health service. And Professor Dame Leslie has talked to that really well for us. Because when we started this work, we already had a heavy menstrual bleeding, dysfunctional menstrual bleeding pathway that we had designed. We didn't have anything that had been nationally endorsed for urogynecology. So where we started was a CLEAR design board, where we brought together experts nationally to map out what an ideal urogynecology pathway would look like. And we then took that pathway and the heavy menstrual bleeding pathway to 2 ICBs, and we supported them to adapt and adopt those models of care to make them work for their local population, for the workforce that they had available, and really just make those pathways work on the ground for them. And alongside that, we worked with Derby and Derbyshire ICB to initially to try and implement their heavy menstrual bleeding pathway. And what we soon found is that it's incredibly difficult to unpick the crossover between kind of 4 of the women's health pathways, and that is heavy menstrual bleeding, urogynecology, menopause, and pelvic pain. And so what we have done is focused on those 3 pathways you see there, those 2 pathways you see there within phase 1 of work, but we are now working with those ICBs to think about how they can broaden that and make their structures work to bring in more pathways and to deliver economies of scale and to deliver care that wraps around women more holistically. And that's something that we've definitely learned and has really come through in the renewed women's health strategy. And what we created was 5 national recommendations for the women's integrated neighbourhood services. We know that we need to build workforce capability and confidence in dealing with gynecological conditions. We need to promote NDT-led conservative management at the first contact and out in the community. Again, holistic, and we've talked to this in the chat already, access to psychology, to dietetics, to physiotherapy without having to hit secondary care and have a long waiting time to access those services. A single point of access is really key in making this work, and there is obviously separate guidance that has come out around delivering that. And so we worked with the ICBs to think about how they can triage their referrals to make sure that the women that can be kept in the community are kept in the community for their care. We worked with them to standardise their data capture. We know that coding is very poor across women's health in both primary care and secondary care. So we've got an approved list of coding that is going to link with the National Women's Health Data Dashboard, so that we can really monitor and evaluate properly the services that women are getting and how they're accessing them, particularly in community services where there may be some limitations on the monitoring that happens at a national level, like referral to treatment targets and things like that. And then finally, strengthening patient information, education and choice. And we've really worked to make sure that our ICBs and our providers are able to provide information to women that empowers them to make decisions about their healthcare, and the choices that they have, and also empowers them to self-manage what they can through whatever issues they are facing. When we've brought together our ICBs here, we have also included primary care, we've included secondary care, we've included local authority commissioned sexual health services, and voluntary sector providers where appropriate, to really deliver a collaborative pathway where women can get the care that they need wherever they present. And as I said, we are still working with these ICBs at the moment, just to really help them realise this in practice. For Derby and Derbyshire, they are implementing as we speak. They are taking a phased approach. So we're hoping to get some outputs and some evaluation metrics from them in the coming weeks. Does anyone have any questions quickly about phase 1 before I hand over to Laura to cover the opportunity for you all today?
I think there are some points in the chat which constitute
That's fine. We will pick those up in the Q&A at the end, I think. Fine. The ones that are in the chat.
There's perhaps there's one around how big the neighbourhoods are, Laura, that might be worth picking up now, because it's helpful context, I think, as we start to talk about phase 2 and the opportunity, being very much focused on neighbourhood teams.
Yeah, so we worked with, so I think the terminology is tricky around neighbourhoods at the moment. As things stand, a neighbourhood is around 50-ish. It's around the size of a PCN, so 50 to 100,000 population. What we have worked with on this programme is a population of 250,000. So the ICB's identified an acute provider and a place of 250,000 population, roughly. Could be a little bit more than that if needed. If their places were smaller than that, we would work with 2 places, but the same acute provider. But we needed to cover a population of at least 250,000, and that's because some of these services, it's not economical to deliver them at a PCN level. So I'm thinking about your psychology services, some of your physio services, some PCNs, just, for a 50,000 population, it just isn't economical to deliver at that level. So if we can...
Could you clarify then, sorry, because then they're not neighbourhood models, they're place models.
It's still aligned with a neighbourhood strategy. So what we do when we work through is we look at what should be delivered at first contact within the practices. What should be that basic expectation? What should each PCN be able to deliver? And then what needs to be delivered at a place level where neighbourhoods will work together. And that might be linked in with things like a community diagnostic centre, linked in more closely with the acute provider and services that kind of span a broader area. So we'll work to both.
I think difficulty is a place as well, because place is different sizes for different organisations.
Yeah, so as long as the population is around the 250,000 mark, and if the place is smaller than that, then we would work with 2 places as long as they feed into the same acute provider.
Which I think is really helpful understanding to take into this next bit around phase 2. You'll see why. If it's okay, I'm going to move us on. We won't take any more questions till the dedicated slot now. So if we have the next slide, please. I'm going to spend a few minutes talking to the opportunity that we're inviting expressions for interest for currently. Next slide, please, Maria. Phase 2 of the Clear Women's Health Programme has been commissioned by NHS England, and it builds on the learning from phase 1 to embed 4 core pathways: menopause, dysfunctional menstrual bleeding, urogynecology and pelvic pain into neighbourhood models of care. And we're looking to work with 3 to 5 ICBs, each supporting up to 2 neighbourhood teams, covering a minimum population, as Laura said, of 250,000 patients per ICB. We're looking to have a spread of regions, so we won't be taking forward more than 1 ICB per region. Next slide, please. There are core pathways for menopause, dysfunctional menstrual bleeding and urogynecology already developed nationally. Pelvic pain is the newest addition. We're just developing that now, and this pathway will be agreed through a national design board, and then, like the other 3, refined locally through Clear Focus. The outcome is not a one-size-fits-all solution. Each system that we work with is going to be supported to adapt those national pathways to their local population need, workforce capacity and existing services. I think it's important for me to say that these 4 pathways aren't designed to sit as separate services. The intention is that they come together within a Women's Integrated Neighbourhood Service, or WIN. So women get joined up community-based care across all of those areas rather than 4 disconnected referral routes. And because we're testing and refining this with a small number of neighbourhoods first, everything that we build with you, so the adapted model, the workforce approach, the value case, is designed from the outset to be scaled. So what you help us prove locally becomes that blueprint that can be adopted across the wider system and indeed other systems. So your input here in this phase 2 work will have an influence well beyond your own neighbourhood. Next slide, please. In terms of how we'll actually work with you, Clear Focus is our delivery methodology. It's a series of workshops which bring together clinicians and system stakeholders to adapt a proven model of care to local needs. So it's, as I say, a series of workshops led by members of the National Clear team. So I'll be involved along with several of our senior clinical consultants, bringing together a range of stakeholders from across your local health system. And in those sessions, we'll look together how a model of care can be tailored to your local population's needs. We will draw on clinical engagement, workforce modelling and scenario planning to test the impact and the cost of any proposed changes, and we'll use data provided by the organisations involved. We've used this same workshop approach successfully in lots of other areas. So, for example, improving same-day emergency care for older people living with frailty, and lots of others per the slide I shared earlier. And the aim is always the same. It's to take a proven model of care and accelerate how quickly it's adapted and adopted locally. Next slide, please. And I think this slide just offers a visual summary of how the Focus project will run in practice. We will be sharing these slides, so I'm not going to dwell on this one. Next slide, please. So I talked a little bit about benefits. How does the Clear Focus actually deliver on these benefits? You know, transformation like this doesn't just happen by handing over a model of care and hoping that it lands. It happens because the right people are in the room working through the detail together, and that's what the workshops are designed to do. It's quite a structured process, and change is very much built on that local ownership and evidence, and it's designed to be sustainable once our support steps back. Next slide, please. The key tool underpinning this, or a key tool underpinning this, is our Cohort Workforce and Impact Calculator, or QUIC tool, which allows us to adapt the model of care to your local population and demand, and to quantify the cost and impact of that new model before you commit to it. So you're not working on assumptions, you're working from a clear evidence case for change. And that's what turns the benefits that we've described from an ambition into something that's deliverable. Next slide, please. And this, again, is just an example visual slide of a quantified output from the QUIC tool. Next slide, please. Something on timings. If we just move to the next one. The expression of interest deadline is 5 p.m. on Wednesday, the 29th of July, which is just about 2 weeks away. Submissions need to be made at an ICB level, and this needs to be done using the online form. We are going to share the expression of interest pack link again at the end of this webinar in the chat, and this will now include a website link to the PDF of all of the expression of interest questions, as many of you have asked for those, understandably, because it allows you to see what the questions are in advance of starting to complete that online form. Next slide, please. Selected sites will be informed in August, and following this, there'll be onboarding and program launch running through August and September, and then from there, we'll start the clinical engagement and data interrogation running through the autumn, and then work through the workshops to do the pathway adaptation, and then the implementation planning continues into January. The program closes in March. So it's just a very sort of high-level overview of the timeline for the program. And that brings us, I think, to the part of today I suspect many of you have been waiting for, your questions, opportunity to ask us. I'm sure many of you have had a chance to have a look through the expression of interest pack already, has led you here today. So deliberately kept the kind of presentation quite light on detail, so we've got as much time as possible for this. Please do use the raise hand function if you'd like to ask your question directly, and we'll bring you in, or post your question in the chat if you prefer, and we'll come back to as many as we can. If there is anything we don't get to live today, or it needs a fuller written answer, we'll follow up with a note after the session. I know Laura's been keeping half an eye on the chat throughout today, so do kick us off if there's any questions that have come in there.
Could we pop the slides? Could we take the slides down, please, Maria?
Good idea.
So yeah, just having a little look through the chat. I've answered a couple of questions in the chat. So the webinar and the slides will be shared afterwards. The coding details that we talked to, they'll be provided within a toolkit that we'll be producing with all of the learning from the ICBs that we've worked with so far. We'll be using that with the successful ICBs when we start phase 2 of the work, but that will also be readily available for any other ICBs to take and start working on themselves. It just won't have the tailored support, obviously, that comes with working with the CLEAR programme. We have also got a request around the neighbourhoods again. So I think there is flexibility on the footprint that we can work with. The key is that we cover a significant enough population footprint that the services are viable to deliver, and that we can demonstrate the impact of having that service. So I think when you fill in your EOI, you'll need to give details of the footprint that you want to work with and the providers that sit within that footprint. So I think as long as you can justify the footprint that you have chosen, we can have some flexibility on how we work with that. But the key is really just getting that 250,000 circa population. Could be a little bit more than that, but really shouldn't be any less than that, because appreciating that people are kind of in different phases with place boundaries and neighbourhood teams. And then a final question that I can see in the chat was opportunity for match funding. So it's not an opportunity for match funding. What NHSE have asked with this commission is that there is a financial contribution from the successful ICBs. Now, we're not specifying what that contribution needs to be, but it's, I think, from their perspective, seen as a commitment to working with us on this to develop the Women's Integrated Neighbourhood Services. So any ICBs that can offer some match funding will be prioritised as part of the programme.
A couple more have come in, Laura, just now.
Yeah. Can you expand on the criteria that specifies?
That's another kind of funding.
Yeah. I think it's like I said, we're not specifying how much funding but any ICBs that do have match funding available, as long as they meet the remaining criteria, which you can see on the EOI questions, they would be prioritised. How much time is needed for key roles per ICB? So we had on the slides, that final slide that Laura just showed, that has some information about what the requirements are. So what we normally do is have a clinical lead, who is somebody that is neighbourhood based. So quite often that might be a GP with special interest that sits within a PCN or within a GP federation or something like that, or maybe someone from the ICB who's working with the ICB in terms of the neighbourhood strategy, but is clinical by background. So we would normally work with somebody like that who would take the lead from the provider side. And they would be required to attend regular meetings with us. So normally every 2 to 4 weeks, just to keep the programme running and help us with communicating the work across all of the providers, and basically giving us as much information as possible. They would also attend the workshops and work on the pathway redesign from those national models that we've got. And we would also expect some input from the ICB, because the commissioning of these services is really key. If we don't get how they're commissioned right, it's really, really hard to make them sustainable on the ground. So we would be looking for somebody in the ICB, and again, very, very conscious that ICBs are in a state of flux at the moment in terms of who's responsible for women's health and for neighbourhoods. So we don't necessarily need, it's okay if that's a different person come September. I think it's about the overall direction of the ICB committing to wanting to develop their women's integrated neighbourhood services.
Some of the questions are circling back to the discussion around population, neighbourhood, place.
Yeah. So we will need, so you can have a group of neighbourhood teams that are co-located to form a 250,000 place. That's fine, but we definitely need a 250,000 population. That's been a stipulation from NHSE. A maximum of 3 ICBs is correct. And we will be looking where possible to spread across England with those. So it's unlikely, for example, to be 3 ICBs from the same region. There is an expectation that the successful ICBs will work with regional colleagues to help share the learning and help other ICBs to move their work forward after the programme. An estimate of expectation for the funding to help with influence. I think we were keen not to set a specific amount for the match funding, because we are very conscious that it might not be achievable. I think really the ask around that is really just about showing a commitment to, put money into developing this and to working with us, rather than a specific amount of money required. So I think it would need to go back into your women's health plans and seeing if you have got money set aside for women's health budget that could be used to support this work. If we are trying to bring women's care closer to home and provide it in primary care, surely it needs to be provided in their locality. Yeah, so absolutely. So that's part of what we work through. So there will be some services that absolutely should be provided within a primary care network, and you should have people that are skilled in providing those services at a PCN level. There are some services like diagnostics, like some of the allied professions, that it is not economically viable to provide at a PCN level, and that's why we look at those at more of a place level to make sure that we can pull in the full pathway of services that are required to be delivered in the community, and not just what should be delivered at a PCN level. It is intended to be a financial contribution rather than in-kind support such as staff time. We actually do provide a backfill payment for the clinical leads, of which there's details of in the EOI pack. So we do pay for the time of the main clinician that will be working with us on the programmes.
That leads in quite nicely, Laura, to the question that come in at the bottom around good skill mix for a project team required for this to work well and move forward successfully. I think
yeah,
it's worth talking about what we do as the Clear team in this, isn't it? And
yeah, so I think in terms of from the successful ICB side, we need the ICB buy-in, because if without the ICB being bought into driving the change to commissioning it differently, we won't get a sustainable solution on the ground. So that ICB buy-in is really, really key. And this is why we asked for the EOIs to come from an ICB as an indication that it is a strategic priority for the ICB. In terms of the rest of the project team, we absolutely need clinician input. So if I talk to the previous work that we've done, we've had gynecologist input, we've had specialist nurse input, we've had GP special interest with special interest input, we've had sexual health clinicians that have all taken part. Because the bulk of the delivery of this work is based within neighbourhoods, it's really key that we have somebody who's got an understanding of locally how services can be delivered within a neighbourhood framework. What the Clear team then bring is the expertise that we've got from the previous work, and what we do is bolster your project management capabilities at a time where obviously that's been very much rationed across ICBs, and we'll work with you to build the relationships across the system, to build the infrastructure that's required to build the case for change to make this work for you sustainably. And then, have you had perinatal teams involved? So we haven't. So the scope of work has not included perinatal so far. We have included, as I said, sexual health and contraception through local authorities, but we haven't. Perinatal services would be out of scope for our work, but that's not to say that while you are working with us, you can't think about how those services would embed into what we are working on with you. So although we wouldn't directly work on that, you can absolutely pull that in as part of your wider work. Thought I just saw somebody's hand shoot up, but
Jenna, did you want to come in, or did we?
It was just around the perinatal. Yeah, sorry. It was just, I think you've answered it, Laura. It's about the perinatal teams. We've got quite a large perinatal service over here in Essex, which will obviously touch it in different ways. So I was just curious whether that had been your experience so far. But
yeah,
that was helpful.
I think we're really conscious that we obviously started small with just the two pathways of urogyne and heavy menstrual bleeding, but as I said in the beginning, we've just found that bundling those pathways together with pelvic pain and menopause, endometriosis, with then a bit of input on the contraception side where that crosses over with some of those other pathways. That really makes sense. It allows for economies of scale in how you deliver it, and it gives a nice, well-rounded service for women. But we're very conscious that women's health is a really vast area, and if we try and change too much all at once, that's really unmanageable for our services. We're already looking at 2 to 3 year phasing to get just those 4 pathways working in the ICBs that we've worked with before. Because it's a big shift in the way we work.
Yeah, absolutely.
Yeah, absolutely. So yes, so absolutely, contraception and sexual health in more detail and perinatal is absolutely on our list of things that we'll be working towards in the coming financial year, that isn't within scope of this work, but absolutely something that you can work on yourself in parallel.
Thank you.
Thanks, Laura. What I'm going to do, questions have slowed coming in and we've just got a few minutes till close, is just start to talk about next steps and close the meeting. So thank you all so much for joining us today. Many thanks also to Maria Acco, who's been behind the scenes before, during and after today's webinar to make sure it's all run smoothly. And huge thank you as well today, Leslie, for a really insightful keynote to the session. For those attending, if you'd like to take it further, the expression of interest deadline is, as I say, 5 p.m. on Wednesday, the 29th of July. Maria's just linked the online form and the information pack and some other information. If you have got any questions after today or want to talk through your EOI before submitting, please do reach out to us. Our details are available at those links. I'm aware, I've popped in the chat, I am aware many of you are attending from, for example, a PCN. If you haven't already, we strongly encourage you to engage with your ICB on the opportunity, not least to understand, as somebody's flagged in the chat, whether or not they would be able to put forward any funding contribution as well. So do that as a priority if it's something that you're very interested in. Thank you so much again, and we look forward to hearing from you. Enjoy the rest of your day.
Bye.
Bye, Leslie.
Bye-bye. Good.